Next speaker is an associate professor of health decision science in the Department of Health Policy and Management and a core faculty member in the Center for Health Decision Science. Her research uses mathematical modeling to evaluate policy interventions, particularly for women's health. She has used a series of models which she developed to evaluate policies to prevent cervical cancer, including screening and vaccination against the human papillomavirus. Her work has targeted not only the U.S., but also Europe and less developed regions of the world, and she received the Association of Schools of Public Health Young Investigators Research Award in 2010. It's a pleasure to introduce Professor Jane Kim, who will speak on the comparative effectiveness of cervical cancer prevention policies using decision analysis methods.
Thank you very much. And with the recent movement in screening technologies, I thought I would focus my talk today on actual screening policy. So cervical cancer is the second most common cancer in women worldwide, with the vast majority of cases and deaths occurring in poor countries. Globally, there are over 500,000 new cases and 300,000 deaths from cervical cancer each year. In the US, despite the dramatic reduction in cervical cancer burden due to widespread pap smear screening, there remain over 12,000 cases and 4,000 deaths each year. It's now well established that persistent infection with human papillomavirus, or HPV, is a necessary cause of cervical cancer. HPV is a highly prevalent sexually transmitted infection. It's estimated that over 80% of sexually active individuals at some point in their life will acquire an HPV infection. In the vast majority of these cases, the infection will clear within 1 or 2 years, but under certain circumstances, that infection can persist and progress into precancer and invasive cancer. There are over 40 known types of HPV that infect the genital tract, of which roughly 15 are considered to be high risk or oncogenic. And in particular, 2 types, HPV 16 and 18, cause 70% of cervical cancer cases worldwide. Just a few things to note about the natural course of cervical cancer, depicted by this graph. The HPV incidence peaks at a relatively early age, so late teens, early 20s, soon after the initiation of sexual activity, which in the United States occurs at a median age of 17. In contrast to that, if we look at the precancer prevalence, which is shown by the green line, we see that the prevalence is far lower and also peaks much later, so in the early 30s. And cancer actually doesn't peak until early 40s, early to mid 40s. So this prolonged natural history process provides ample opportunity for prevention along the disease spectrum. And now we have prophylactic HPV vaccines as well as screening. But they also pose challenges, the natural history process poses challenges for evaluating prevention strategies, since it would require decades of follow-up to observe any reductions in cancer. The traditional method of screening has relied on the pap smear, which is used to detect precancerous lesions that can be treated and removed. And despite the widespread use of pap smears in the United States and many other countries, the low clinical sensitivity of a single pap has required repeated screening to achieve programmatic effectiveness. A relatively new technology is HPV testing, to test for one of the 15 high-risk HPV types that cause cervical cancer. And HPV testing has been found to be consistently have higher sensitivity in detecting precancers, but at a lower specificity than pap testing. The use of the HPV test in the United States has been reserved for a triage test for women with an equivocal pap, or in combination with pap as a co-testing strategy in women over the age of 30, at least up until recently. I'll talk about the change in a minute. There are also newer technologies that allow for genotype testing for particular HPV types, as well as biomarker tests that are designed to improve the specificity and better stratify risk in the population. So with better information on the epidemiology of the disease and with continually evolving new screening technologies, there has been a shift in cervical cancer guidelines. In 2012, recommendations for routine screening, cervical cancer screening, were for the very first time harmonized across major guideline-making organizations. And there were two major provisions that were emphasized in this set of guidelines. The first was a very strong recommendation against screening in women under the age of 21, and that's given the very, very low risk of cervical cancer in this age group. The second was a definitive shift away from the traditional paradigm of screening every 1 or 2 years, which had been guidelines for many, many years, with a recommendation to extend the interval of screening to 3 years when using a pap smear, with an option to switch to HPV and pap co-testing at a 5-year interval at the age of 30. And just about 3 weeks ago, the FDA approved HPV testing alone for primary screening in women age 25 and older. And again, although clinical studies have demonstrated the superiority of HPV testing compared to PAP, when and how often to screen women with this test is unclear from these empirical studies. So given the wide range of options that we have for screening, not to mention vaccination, my team and I have used a decision analytic approach to inform both clinical and public health guidelines, both in and outside the United States. Decision analysis is an explicit, quantitative, and systematic approach to decision-making under uncertainty. It involves identifying, measuring, and valuing the consequences of decisions, as well as taking into consideration the uncertainty and the risk that exists when the decisions are made. The critical elements of a decision are incorporated into a model to structure that problem over time, and the model is then used to compare the expected value of different options or interventions. And there are many different types of mathematical models that can be used. We've referred in discussion about mechanistic models, and this is an example of one of them. This is a very simplified schematic of our disease simulation model of cervical cancer natural history. The boxes represent health states that reflect key stages in the course of disease, and the arrows that you see represent the allowable transitions between these health states. A cohort of simulated individual females enters the model at a young age with a healthy cervix, and then can face risks of acquiring HPV infection that can then clear or progress to precancer. That's classified as CIN, cervical intraepithelial neoplasia, grades 2 or 3. And that precancer can then develop into invasive cancer. In our model, transitions between these health states are dependent on a woman's age, also HPV type, and a woman's history with prior HPV exposure, as well as screening and treatment and vaccination status. And the model tracks clinical events and health expenditures over the lifetimes of these individual women, which are then aggregated at the population level. These models are quite data intensive, requiring information about the natural history of disease. We want information about screening test performance and treatment efficacy, the cancer burden, so incidence and survival, as well as costs and health state utilities when we're interested in reflecting quality of life. Because not all model parameters can be directly informed by the data, the models can be calibrated to ensure good fit to observe data by adjusting uncertain model parameters. This is just an example of model calibration results that depict HPV prevalence by type and by age. And the green lines represent the bounds of the data on HPV prevalence in a US population, and the red squares represent our model fit. We also undergo model validation exercises to assess the model's ability to predict outcomes that are consistent with data that were not used in model development. And so here we show model validation against cancer outcomes when we turn screening on in the model. And so when we simulate current screening rates in the US population, we find that our model outputs compare favorably to multiple cancer endpoints that are reported in the US CER cancer registry. There are multiple outcomes that can be projected from our model, including health outcomes. Intermediate outcomes can be reductions in HPV prevalence or cancer cases, as well as long-term outcomes, which typically are around life expectancy, either adjusted or unadjusted for quality. Economic outcomes can reflect short or long-term costs of interventions, and typically include the direct costs of the interventions, and as well as patient time and transportation associated with the interventions. Now, as already mentioned by Steve Gortmaker, in a cost-effectiveness analysis, these measures are combined into a common metric known as the cost-effectiveness ratio. When we are interested in competing health interventions, we calculate the incremental cost-effectiveness ratio, which is defined as a net increase in healthcare cost divided by the net gain and health effect of one strategy compared to the next less costly strategy. This ratio is expressed as a cost per unit of health benefit, so for example, dollar per quality adjusted life year gained, and is a measure of value for resources. And while there's no explicit cost effectiveness threshold below which an intervention would be considered good value for money, ratios of $50,000 to $100,000 per quality gained are commonly cited in the United States. So in our evaluation of cervical cancer screening policies, we've simulated strategies that reflect Pap testing at age 21 at intervals of every 1 to 5 years, just to reflect kind of previous practice or current practice, as well as with a switch to Pap and HPV co-testing at age 30 at 5-year intervals. And again, this is consistent with the 2012 routine screening guidelines. When we evaluated HPV primary testing strategies, we looked at Pap starting at age 21 and then different switch ages to primary testing, including 30, 27, and 25, at intervals of every 3 or every 5 years. And then in an exploratory analysis, we evaluated just initiating screening with HPV primary testing at age 25 without any preceding Pap smears. Excuse me. In the 2012 guidelines deliberations, the American Cancer Society and the U.S. Preventive Services Task Force wouldn't consider costs as an outcome. So instead, they used the referral rate to a diagnostic colposcopy as a proxy measure of harms. And so this graph depicts the number of colposcopies per 1,000 women screened for a Pap testing strategy of every 1 to every 3 years. And with annual screening, we see that the colpo rate is over 1,800 per 1,000 women screened. So this implies that on average, if you were to get screened annually, you would expect nearly 2 colposcopies over the lifetime of screening. When we extend the screening interval to every 2 years, that colpo rate reduces by over 40%, and when we extend to triennial screening, every 3-year screening, that colposcopy rate reduces by over 60%. When we evaluated or simulated the 5-year co-testing strategy, a switch to co-testing at age 30, the model projected that the colposcopy rate increases slightly compared to the 3-year Pap strategy. And then when we evaluated switching to primary HPV testing at age 25, we found that at a 5-year interval that the colposcopy rate was actually lower than the 2 recommended strategies, the 3-year Pap and the 5-year co-testing, but that they were higher with more frequent screening at every 3 years. The red diamonds represent, and the corresponding secondary axis, y-axis, represents the reductions in lifetime risk of cancer associated with each of the strategies. And not surprisingly, we see that a higher colposcopy rate is generally accompanied by a greater reduction in cancer risk. But there were a couple of things to note. The first is as we move from annual screening, Pap screening, which is shown on the far left, to strategies that involve less frequent screening, the large drop in colposcopy was accompanied with a relatively small drop in cancer benefit. Another thing that we noted was that the 5-year HPV primary testing strategy had a lower colposcopy rate and higher cancer benefit when compared to the currently recommended strategies of 3-year PAP and 5-year co-testing. So even though costs were not explicitly considered, it was hard to value these strategies in terms of colposcopy rates and cancer reduction rates. And so cost effectiveness analysis was nonetheless informally considered in the guidelines. And so what I'm depicting here is an efficiency frontier, and with quality adjusted life years, or QALYs, along the y-axis against lifetime costs along the x-axis of each of the different strategies that are indicated by the colored symbols. Note that we're operating on that upper right quadrant of the cost effectiveness plane that Steve Gortmaker had introduced previously. And so as we're marching up the efficiency frontier from the lower left to out to the upper right, we are gaining QALYs, but at a higher cost. This red circle represents a scenario of no screening, which is not a viable option here in the United States, but it was used as a baseline scenario. And the green diamonds represent PAP testing at intervals ranging from every 5 years on the lower left out to every 1 year on the upper right. And we can see that they correspond to increasing cost effectiveness ratios. The strategy of switching to co-testing for every 5 years at the age of 30 is depicted by the orange triangle. And what we found was that the strategies that are recommended under current guidelines, the 3-year PAP and the switch to 5-year co-testing, have similar positions on the efficiency frontier, and both have cost effectiveness ratios that were close to $50,000 and well under $100,000 per QALY gained. Another thing to note is that the previously recommended guidelines, which emphasize frequent screening of every 2 or every 1 year, can be found on the very flat of the curve on the upper right with exceedingly high cost effectiveness ratios. And when we simulated current practice, which is shown by the turquoise square, which reflects variable screening rates, so some women getting screened annually and some proportion of women not getting screened ever, we found that current practice is actually quite inefficient. And so it had higher costs and lower effectiveness than either of the 2 recommended strategies, even going as far out as every 2-year PAP. So very inefficient practice. When we included strategies that involved HPV primary testing, we found that starting PAP screening at age 21, switching to HPV primary testing at age 25 or 27 at 5-year intervals were more effective at a lower cost than the currently recommended strategies, which are now off the efficiency frontier. And these 5-year HPV testing strategies had cost effectiveness ratios that were near or below $100,000 per QALY. Excuse me. Meanwhile, HPV primary testing at a 3-year interval was either off the efficiency frontier or had ratios that exceeded $170,000 per QALY gained. And in our exploratory analysis, where we initiated screening at age 25 using HPV primary testing without any preceding PAP smears, we found that HPV testing at a 5-year interval had a very attractive cost effectiveness ratio of roughly $11,500 per QALY, and that the other HPV-related screening strategies had very high cost effectiveness ratios. And this strategy of starting screening at 25 and conducting it every 5 years was again more effective and less costly than the 2 currently recommended strategies. Just a couple of key insights from these analyses. In the absence of HPV primary testing, our analysis supports the 2012 screening guidelines recommending PAP every 3 years, with or without a switch to co-testing every 5 years at the age of 30. Both of these strategies were found to be cost-saving compared to what we're doing now, current practice at variable screening rates. And when considering HPV primary testing, we found that HPV testing alone at 5-year intervals, starting at age 25 or 27, yields greater benefits at a lower cost and with fewer harms, as measured by colposcopies, than currently recommended strategies at an attractive cost per quale. Furthermore, initiating HPV primary screening at age 25 without prior PAPs may be a cost-effective alternative. Thank you very much. Happy to take questions.
Jane, what did you assume about vaccination here? Were these analysis, is the target population here all women, including some who've been vaccinated and some who haven't? Or are you assuming that the current adult cohort, for the most part, has not been vaccinated?
Exactly. So the evidence bears out that way. The uptake of the vaccine in older women is actually quite low. This was assuming unvaccinated women, basically, and largely because in the 2012 American Cancer Society guidelines, there was a decision to not differentiate screening policy between unvaccinated and vaccinated women, simply because there wasn't enough empirical data about how to change screening in vaccinated women, and I think people felt uncomfortable making the policies too complicated, even though they are already very complicated. So this was for an unvaccinated population. Hi, Sarah.
Hi, Jane. Jane, so thank you. Great talk. And so my one question is, as you know, as you mentioned, the effective prevention of cancer depends on not just the screening, but then the management of abnormalities and the intervention related to an abnormality. So currently the management guidelines from 2013 are very complex, and that's part of the problem.
Right.
And so and also just to mention, in the recent Athena trial, they looked at only one HPV test, and they looked only in 4 management strategies, none of which are really what we do in the United States. So my question for you is, in your model, when you do primary HPV screening starting at 25, what is the threshold for evaluation? What's the next step? Do they get reflex cytology, or do they go straight to colposcopy, and does every abnormality get a colpo?
Sure. So the short answer is that we've evaluated all of the Athena strategies. So these are complex combinations of different follow-up management strategies for women with HPV 16, 18, or any of the high-risk types, or and so. For this particular analysis, what I showed was I think the intended strategy when the FDA approved, which is colposcopy for 16, 18 positive women, and then having the women with other high-risk types return for HPV primary testing in a year. So. Oh, I'm sorry, the cytology triage. I'm sorry. Yes, not a repeat. Right. Right. Mm-hmm. That isn't confusion, right. Yeah, I mean, it's complicated because there's not only the different guidelines in terms of management. So routine screening guidelines were harmonized, but the management still remains pretty subject to whatever organization you're talking about or talking to. And then that's not to even mention the actual variation in practice. And so for this analysis, we did the cytology triage for the other high-risk types. I was thinking about the co-testing, which is a repeat co-test in 12 months. But we can look at all variations of the follow-up because we do stratify by these different high-risk types.
Okay, we have 2 more questions.
Thank you for your talk. First question relates to, do you have any sensitivity analyses and backup you could share with us? And second question is, have you considered taking a multi-criteria decision analysis approach to investigate this phenomenon?
Yes and yes. Did you we should talk about what type of sensitivity analysis that you're looking for.
I'm wondering, can you speak even at a high level to
Sure.
What parameters your model was most sensitive to and where you saw the greatest amount of variability?
Absolutely, absolutely. So when we did do some uncertainty analysis around this, we found that the results in the rank ordering the strategies are quite robust. So I think we have a lot of work to do in terms of modeling all the different variations of screening and management, as well as test performance and things. So still a lot of work to do, but I'm happy to share it with you in particular, if you're interested. Multi-criterion decision-making. I mean, that's really complicated. I mean, there are a lot of things that we could do to improve the decision-making process. This particular analysis includes health outcomes, quality of life, and costs. We know that there are other goals that we wish to strive for, which is, has to do with reducing the disparities that we see in cervical cancer burden in this population. And so we have not incorporated that in particular in this particular analysis, but we are doing targeted analyses to look at interventions and whether or not there could be high priority interventions to be able to minimize, let's say, disparities or minimize.
Thank you.
Yeah, sure.
Okay, last question.
Hi, Jane.
Hi,
I wanted
Josh.
to ask you a question about the politics of talking about costs. Because it was really interesting, I think, what you presented in the sort of acrobatics of having to proxy it with colposcopy rates. So, you know, unlike the ACA, in the case of the U.S. Preventive Services Task Force, their authorizing legislation said that they would look at costs, effects, and cost effectiveness. But we're in a climate now when nobody will touch costs, including the Preventive Services Task Force. So I'm wondering if you could just actually tell us a little bit about how you covertly were able to introduce costs and cost effectiveness into that discussion.
Sure.
When people are so cautious about
Yeah.
avoiding that in this day.
Well, I mean, I can be honest that it wasn't very covert. I mean, there were very explicit requests from you know, the leaders of these guidelines committees for this data and for particular analyses. We just couldn't talk about them in our guidelines, and there were references to cost effectiveness, but not really as a measure of cost, but more as a measure of efficiency to back up what we were finding in terms of colposcopy per cancer detected. And so it is interesting because I find a very, very strong demand by decision makers who even, you know, technically have to be at arm's length with cost and cost effectiveness analyses, who are really still kind of under the hood or trying to get this information. So it wasn't, you know, during the 2012 guidelines deliberations process, we talked very openly about costs in that session, and we just didn't write about it. And we kind of sought other proxy measures that would convey the messages about efficiency about each of these, the comparative efficiency about each of these strategies through other intermediate endpoints.
It's interesting, you know, this has been true my whole career. You know, there's sort of a double standard for clinical care and prevention. Your topic is really in between, but maybe even a little closer to clinical care. It's things that doctors do in their offices. And it's against the rules to talk about cost when it comes to clinical care, but it's certainly not against the rule to talk about the cost of prevention. And in fact, you know, the CDC talks about cost all the time. The Advisory Committee on Immunization Practices,
Yes, absolutely.
which I know you've worked on HPV vaccines and other vaccines, they demand evidence on cost effectiveness in order to reach recommendations about vaccines. So I think we've sort of gone backwards a little bit, and you know, it started to be sort of acceptable to talk about costs, and of course the journals still have cost effectiveness papers, but if you're funded by a government grant, it's you know, it gets a little dicey. But for public health, sure, you can talk about how expensive it is
Right.
to do public health.
Right, right. And so these guidelines are really meant to be national guidelines for, I mean, it is public health, I would argue, but, you know, we had clinicians and providers who were on these committees as well, who just brought in a different perspective. I didn't think that either one was right or wrong. It was just, you know, we were kind of landlocked at certain times.
Yeah.
So,
Thanks so
thank you.
much, Jane.